This is Heart Disease Indicators, an analysis through decision tree modeling by Adam Fowler, Tyler Sanchez, and Jacob Unger. So what were the goals in the questions that kind of we wanted to answer with this project? And that first one, are we able to accurately model a way to predict heart disease based on the attributes that are common indicators of poor coronary health? And this goal was pretty straightforward, helped us guide the path of the project, and it required us to use different models and look at their associated statistics to determine which one would be best suited for our two following goals. And one of those being which of these attributes are the most important factors when determining risks of coronary heart disease. And most of the data we looked at regarding heart health focus, many of the same health, they used many of the same health indicators, but we noticed that there was a gap and that no one was identifying key features that could be used as a quote unquote gauge when quickly determining if further health measures were needed in a patient or patient population. There are a few reasons for this. The best one that we concluded is likely there isn't a singular factor that towers above the rest regarding prediction because it's such a complex system that you're trying to analyze that relies on many factors. Secondarily to this, none of the data that we entertained had anything to do with the individual, and therefore we can determine as a key factor in one person isn't necessarily population applicable. So we had to aim to grab the most important attributes of the data as applied to the population. And third, how can we make this information more approachable and digestible to the general public? And one of my big gripes with scientific information is it can be very difficult to access and digest unless you're part of the niche community that was involved in that research or putting that information together. So we also wanted to create a very simple web tool that would allow us to disseminate this information to a more general population. So applying that model to tell a user whether or not they're at high risk of heart disease based on the factors that they input into it.
When it came to the data preparation for our data set, the first thing that we had to do was we had to create bins for each of our attributes. We had two different types of attributes. We had binary and ordinal. For the binary, it was pretty simple. It was just the yes or no bins. For the ordinal, it got a little more complex. We had a few different ordinal variables. We had body mass index, age, education, income, mental health, and physical health. Only some of those had to be reduced. The main format that we took for reducing those was we just grouped them together to make it easier to work with. Those attributes that we were binned were the body mass index, mental health, physical health, and then for our diabetes, we converted it to a binary binning where it's just the yes or no question. After that, we had to check for clean data. Our data set was pretty clean to begin with, especially with having so many binary attributes. A lot of them are just yes or no questions, so we didn't have to do a lot of work there, which was nice. The next part that we did was we graphed the data. This was like our initial analysis to kind of see how the attributes affected heart disease or heart attacks. And then the last thing that we did for our data preparation was this went along with our decision tree. We had to resample some of the data to compensate for a class imbalance. What we did was, or we had a really high accuracy, but low precision and recall. And then when we resampled this, our precision and recall increased, but it was at the expense of the accuracy. So here are two of the graphs. The first graph here shows the heart disease compared to high blood pressure, which was one of our top attributes. It shows four different categories: the false, 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 true, true, false, and true, true. The first being true or false on the heart attack or heart disease, and the second being true on the high or true or false on the high blood pressure. As you can see, when it comes to true for the heart attack or disease, which is the two bars on the far right, there's a lot more where they have high blood pressure than when they don't have high blood pressure, so we can kind of see that that's an attribute that leads to the heart disease. For the second one that shows age group, the blue line is that false for heart attack or disease, and the orange line is for true for heart attack or disease. And as the age bins get higher, that's higher in the age. And as you can see, the true for the heart disease gets a lot higher as the age increases as well.
We used a number of Python libraries for this project. Pandas was used to load the CSV data into a data frame, create bins to quantize some variables and remove the original variables from the dataset, and write the data frame back to CSV for further use. It also allowed us to sample objects from each class in order to compensate for class imbalance. Scikit was used to split the data into training and testing sets, fit the training set to a decision tree, and test the model. The resulting model object was pickled to a file so it could be loaded later for further use. Matplotlib, Seaborn, and NumPy were used to create confusion matrices, and GraphViz was used to visualize the resulting trees. These were useful in tuning the classifier. Finally, Flask was used for a web application that used our trained model. The data frame was passed to Scikit to split the dataset into an 80-20 split training and testing set, which was fed into the decision tree classifier. Decision trees tend to overfit when a large number of variables are used, so the tree was tuned by trial and error by adjusting the maximum depth and the minimum number of leaves required. The original dataset gave a very high accuracy of 0.91, but the precision and recall were very low. By balancing the classes in the training set, precision and recall were increased at the cost of some accuracy. The F1 score and accuracy of the resulting model are around 0.75.
So addressing some of the knowledge gained, one of the studies that I looked at post-formal literature analysis covered more specifically classifying individual attributes, and that was able to back up a lot of the findings that we determined using our modeling techniques. So the strongest indicators were not all that surprising. The order was a bit surprising, with general health ranking being the number one for importance for our model, and smoking being of lower importance, which is a little bit counterintuitive to what we've been taught. Questioning some of the information, unfortunately, the paper wasn't very clear about that attribute, general health, and kind of what it meant, as they also used other attributes such as occurrence of physical activity, difficulty walking or using stairs, other things like that that could be kind of classified as general health markers. So I would have liked to see a little bit more information about how general health was rolled up, and that would be something that these studies could take as a direction in the future. Some of the surprising attributes that didn't make the cut here are on the left. Alcohol consumption, level of activity, BMI, and diet all played small enough roles in the model outcome that they were dropped from the final model. All these things are largely contribute to overall general health. So kind of, again, harping back to that point that I made previously. And it's interesting that these played rather non-significant roles, as they are generally considered rather important health markers. Things like income level are understandably less important. However, there are plenty of studies that have been done correlating income level to general health standards through access to things like better diet, exercise, and non-physically demanding jobs. So tying all back into one of the observations about the questions that we set out to investigate, it's oftentimes these very complex web of factors that contribute to poor coronary health, and it's difficult to keep on top of all of them when making accurate models. Last but not least, after generating all these models, we still wanted to determine what purpose they could serve, and because frankly it's not a super interesting diagram to look at, that being the decision tree, it's complicated. The numbers don't really mean a whole lot to anybody who was external to the creation of the model, and it's just a lot to digest. So, going back to that original goal, we created a small web application built using Python Flask, HTML, CSS, tying in Jinja to get the dynamic results and all of the modeling that we built. And it's super easy to tie in with that Flask framework. Using those 7 factors that played an influential role in the model, the user inputs those answers, and through that we're able to output a binary of determining whether or not they are high or low risk for coronary disease. This is a really good start to getting that information out there and make it more accessible, but it's certainly not the end.